Hey guys, and welcome back to Clinical Physio with me, Phil Richards. In today's video, we're going to be taking you through all you need to get started with observation at the ankle joint. We're going to be breaking down our observation into an anterior, a posterior, a medial and lateral view. And we're going to be highlighting key traits and pathologies such as an ATFL sprain or a peronei muscle lesion as we go. So as to not slow your video down, we're not going to be comparing the affected and unaffected sides, but of course in practice we always want you to compare the two to form your patient diagnosis. A quick note on the foot and ankle before we get started. The foot and ankle for me personally is a very fascinating subject. There's about 33 articulations in the foot and ankle, and you've got to think of a rear foot, a midfoot and a forefoot. It can be very complex when we're starting out. I'd like to break it down into two joints to make it simple and effective when you're starting out. So we're going to think of the first one, which is the talocrural joint, and that is the articulation between the tibia, the fibula and the talus. And what it's going to do is this plantar flexion, dorsiflexion, this up and down motion. That's the first one. The second one I'd like you to think about is the subtalar joint, and that is the articulation between the talus, this dome shape here, and the calcaneus. And this is responsible for this sliding, gliding in and eversion type motion. But before we get to that point about thinking about specific observation, we need to think about globally inflammatory signs and bony deformity, because regardless of what body part you're looking at, we need to think about those things first. And in case you've forgotten your inflammatory signs, they are redness, swelling and bruising.
So there are 5 key presentations in which you are highly likely to find inflammatory signs that every good clinician should be aware of. Number 1 is a trauma. With any trauma, your patient may suffer bony or soft tissue injury, such as a fracture or a ruptured muscle. Expect to find either swelling, bruising, or deformity when observing the joint. For more severe cases, you may find more than one of these signs present. Number 2 is a bursitis, which put simply is inflammation of a bursa. Some bursae are more easily seen when they are inflamed. For instance, olecranon bursitis, or student's elbow, can be easily visualized as the bursa is right beneath the subcutaneous layer of the skin. Others are not so easily visualized due to their anatomy. For instance, subacromial bursitis, where the bursa in question lies in a relatively deep position underneath the acromion. The amount of swelling seen therefore varies based on the anatomical site and the severity of inflammation. In the event of a bursitis, you may see redness on the skin and feel warmth on palpation. Always consider whether this could have been caused mechanically or whether an infection is responsible, in which case your patient may be systemically unwell. Number 3 is a tendinitis. When you look at the tendon in question, your patient may get swelling and redness in the most severe forms. Be aware though, don't rule out tendinitis if these signs are not present. You should also rely on your objective tests and mechanical signs. Number 4 is an infection or a cellulitis, where you may find redness or swelling, or in progressed cases even pus in the area of infection. Furthermore, look at your patient as a whole. Do they feel unwell, or do they have a temperature? Finally, number 5 is arthropathies, which can be categorized into osteoarthritis, rheumatoid arthritis, and crystal arthritis. For osteoarthritis, you may expect to find an enlarged swollen joint, and in progressed cases, you may find hard swelling when you palpate the joint. With rheumatoid arthritis, you may find redness or swelling at the joint you are assessing, as well as other joints, particularly the hands and the feet. The onset of rheumatoid arthritis is insidious, so if your patient history indicates an absence of trauma, this should be considered a potential pathology. If you suspect this condition, you may wish to liaise with your patient's GP to conduct blood tests to rule out raised inflammatory markers. Crystal arthropathies represent a group of conditions associated with the deposition of mineralized material, mimicking crystals, within joints and surrounding tissues. Gout and pseudogout are some of the most recognizable forms. These conditions present typically in a single large joint with redness and swelling and may well be warm to palpate. Like with rheumatoid arthritis, the important things to bear in mind are whether or not the onset of symptoms can be linked to a mechanical cause and whether mechanical aggravating or easing factors can be associated with the patient's symptoms. If not, a crystal arthropathy should be considered, and the patient should consult with their GP for further investigation. So those are our inflammatory signs. Let's get into the main video.
So we're going to start our ankle observation by looking globally at the patient. The reason we're going to do this is foot mechanics will change when you're weight bearing and when you're not weight bearing. So it's super important to check this first in weight bearing. So I'd like you to think of the foot as going to be of one of three positions. We're going to think of it as either pronated, supinated, or neutral. If we think of a pronated foot is one where it rolls in a lot more, a supinated foot where it rolls out a lot more, and neutral, common sense would say, would be somewhere in the middle. We're then going to look further up at the body and see if the subject is twisted or they've got their head slightly turned in one way, and that might also be impacting up and down the chain. If you notice this when you're assessing someone, you might need to consider their lifestyle or hobbies or their occupation and go into more detail about that, see if that's actually the cause of the problem. So after we've done that anterior look, so the foot, supinated, pronated or neutral, and general body shape, we're going to turn and look at the subject from a lateral view. The most important thing you're going to look for here, other than just your general posture, is at the calf. A tight calf will look like it's sort of bowing back this way, where the shin bones look like they're hanging back from the heel bone. And a tight calf can lead to quite a lot of ankle pathology, so it's worth paying attention to. And then finally, if we get Polly to turn around this way, from a posterior view, the main thing I'd like you to think about is what the heel bones are doing. Whether they're tipped in and they're more pronated, or whether they're more tipped out, supinated, or again, somewhere in the middle, neutral. Okay, if we can turn you back round. And that concludes our global scan on the body, checking for ankle pathology. So next we're going to do ankle observation in a lateral view and a medial view. So we just get Polly to put her leg out straight. So if we look at the lateral view of the ankle, the most key common things you're going to see is what we're going to go through now. So the first one to look at is the lateral malleolus. In instances of trauma, you may see some deformity here, or it's common for patients to have metalwork known as an orif put in down here, so you might see a misshapen fibular bone here. The next common thing you're going to see a lot in practice is lateral ankle sprains from an inversion injury. So you might see a lot of redness and swelling around this sort of region. The most common structures that are irritated here are the ATFL. And underneath here is the superficial perineal nerve, which also gets quite irritated. And it also tends to have a big impact on stretching out the peronei group. So just generally, you'll see a lot of redness and swelling around this area. Moving down to this little bump here, this process, which is the styloid process of the fifth metatarsal. When we talked earlier about whether a foot was too much pronated, supinated or neutral, it's quite common for a supinated foot to see a very sort of prominent part here where the forefoot adducts over. So that can be a little clue for you that they've got a supinated foot. I think that sort of covers about that. So if we get Polly to bend that knee up, and we'll have a look at the medial aspect of the ankle. And again, similar to the lateral one, the first thing you're going to do is look at the malleolus and make sure that's not misshapen from a bony trauma. We're then going to slide down to here around where the deltoid ligament comes in. This is commonly not injured in ankle sprains, but you can, from forceful trauma down into the heel, or in some cases an extreme turn in like so, you will see redness and swelling around the deltoid ligament. The other key thing to look out for, which is super common, is people that excessively pronate tend to have their big toe coming in like so, a hallux valgus. So looking out for that could tell you that they're pronating a lot. It's another big clue. And also if it's in this position too much and they're getting pain around the area, that's probably from a lot of joint discomfort. And that concludes our views on the lateral and medial side of the ankle and ankle observation. We're going to move on to the anterior and posterior view next. So next we're going to do observation of the ankle joint in an anterior view. The first thing I'd like you guys to look for is the extensor compartment of the ankle, and these are the dorsiflexing muscles. Tibialis anterior, extensor digitorum, and extensor hallucis longus. It's important to see if the muscles here have been hypertrophied and overactive, and they may appear enlarged because of this. And as a side note, if you have someone who has restricted dorsiflexion and they have not responded to a calf stretch, it may be worth considering if these guys here need to be released in order for that dorsiflexion range to be achieved again. Moving down from here, we're looking at the anterior subtalar joint, and this is commonly enlarged in an osteoarthritic patient. It will have just a kind of general thickening around here and maybe a bit of boggy tissue surrounding it. Not a convincing redness or swelling, but it will just have that sort of enlarged appearance. The other time you can see a more prominent appearance here are in footballers, where from kicking and the ball stress coming down onto here will cause this lipping formation on the bone. Moving down to here, we want to look at the toe extensor activity, and overactivity here could indicate that there's a tight calf and the foot is having to actively pull itself up, a lot harder to achieve its dorsiflexion. And then finally, we're going to look at the big toe joint, the first MTP, metatarsal pharyngeal, for a condition known as hallux valgus, where the big toe is pulled into this way. The most common reasons for this are overpronation. And what happens is it just causes this joint here to be stressed away from the midline and can cause pain and irritation around that area. It's also very common to get arthritis in this joint from the continued irritation over the years. And that concludes our ankle observation in the anterior view. So next we're going to look at the ankle joint from a posterior view for our observation. The first thing we're going to look at is the calf. And we're going to firstly think about the calf bulk. If we can see a lot of calf, so gastroc hypertrophy here, we might suspect that this is also very tight and restricting the ankle into dorsiflexion, which will cause excess pressure in the foot. So to relieve that pressure, you may wish to include a calf stretch in your treatment regime. The other thing to consider on observation is the potential risk of a DVT. This may appear as a hot, swollen calf, and on palpation we'll get into later, pushing in the midpoint of the calf and forcing the foot into dorsiflexion are other tests you can do to confirm the potential presence of a DVT. It's important to consider someone's age, their medication, whether they've had recent surgery also as an indicator of whether that's occurred. The next thing to consider is any sort of gapping that you might be able to see anywhere down the calf really, but the most particular common points are getting more towards the Achilles tendon. So here and here. If you're seeing any gapping here, they might have had a calf tear, which can be either a partial rupture or a full rupture. And as I said, that can be from about here and also into the Achilles, so you might see a gapping further down here. If they present with Achilles tendonitis, then you might see a lot of redness and swelling around this region. Or you might see it slightly on the sort of posterior lateral or medial aspects, depending on which area of the tendon's been irritated. And also there's a tendinous calcaneal insertion here which can become red and irritated. You might see an enlarged lump sort of appearance here, which would also be indicative of Achilles tendonitis. Moving down to the heel, on this part here is the fat pad, and if people weight bear too much in here, you might see this as sort of enlarged and puffy and a bit red. And moving down to this aspect here on the plantar aspect of the calcaneus, this is where the middle cord of the plantar fascia inserts, and in people that have plantar fasciitis, in more extreme cases, you can see a lot of redness and sort of swelling around here. The other thing lastly to consider in the foot is sort of callus formations on different parts of the feet, which when we talked about earlier in the videos, whether people are more pronated, supinated or neutral, the areas of callus formation might give you a clue as to what their foot's actually doing, and it might help you categorize what they are. And that concludes our ankle observation on the posterior view. So, let's summarize this video on observation of the ankle joint. In standing, break down your observation of the ankle into an anterior, lateral, and posterior view before bringing your patient into a supine position and observing the joint in an anterior view. Remember to compare both affected and unaffected sides. When observing your patient, look for deformity and inflammatory signs, which are redness, swelling, and bruising. You can also look for signs of specific pathology in each view, as mentioned throughout the video. And that concludes our video on observation of the ankle joint. From here, we'd suggest you look at other videos in the clinical physio catalogue, such as active range of motion testing of the ankle and resisted tests of the ankle. Guys, thanks so much for watching. We'll see you again soon on Clinical Physio.